Okay, hi, my name is Brett Edwards. I'm a Masters of Sports and Exercise Medicine student. This is my submission for lumbar spine assessment of Module 3 as the module assignment. My colleague will be helping me out today, so we'll begin. Typically, I would like to assess any lumbar spine problem as they walk in the door. See if they are limping, if they are leaning towards one side, possibly a discogenic issue, and just assess their general movement, if they are extended, or how do they sit down, how do they remove their shoes, how do they remove their clothing, anything like that. Once the history is taken and we get into the assessment, I'll have them walk forward and just monitor how they walk, any limping, turn around and we can walk back to me. Good. And we're just looking for any limping, any imbalances, any changes in weight bearing position, any grimacing once they put their foot down on the floor, any of those to indicate, give you an indication of where to assess further. Next, I would then like to assess the S1 monitor by just getting them to do some tiptoe walking. So again, just looking for any imbalances and walk back to me. Good. And then heel walking, please. And just comparing left and right, and that's fine. You can come back to me. And how they're doing it, if they have any pain. Okay, can I be standing here, please, facing that direction? Okay. Typically, I would undress the patient to allow me to observe landmarks, any prominent features, any scarring, bruising, muscle bulk assessment. I would look at any scoliosis potentially, and analyzing the hips. Just lift that up. Analyzing the level of the hip, so from all of the level of the shoulders, scoliosis, as I said, the levels of the pelvic region, levels of the PSIS, and then muscle bulk and looking into gluteal folds, gluteal creases, as well as lower down. You face this direction. Okay, from a lateral view, you're looking for a normal cervical lordosis, thoracic kyphosis, lumbar lordosis, assessing any anterior or posterior pelvic tilt, any knee or ankle position, any deformities within those factors. Then we'll go through active range of motion. So typically from the lateral view, I like to, one, just assess lumbar flexion by getting her to keep her legs straight and go down to your toes. Thank you, and come back up. And then I like to do it again with my fingers over PSIS on either side. Okay, repeat that please. Thank you. And come back up. And again, just looking at the level of my thumbs, analysing if they're moving equally or if there's a discrepancy in one part of the PSIS may go a bit further than the other. Also helping with any SIJ assessment, which we'll include in this assessment. Okay, extension, hands on your bum, sliding back down. Good. Monitoring that movement, you can face me. Okay, hands on your side, sliding down one side and the other. And again, you're just assessing for any equal movement on left and right. Also noting how far the patient is able to go and documenting that. So in terms of flexion, she's able to fingertips go to the floor, or in terms of extension, fingertips are able to go to the back of the knees. and documenting that as you go along through your assessment. Next, if you wouldn't mind facing that way again, we'll do stalk test. So I like to position myself here with one thumb on S2 and the other on PSIS. So we'll assess the right side first. So my left thumb will be on S2, right thumb on PSIS. Put your weight on your left leg and bring your right knee to your chest. Right knee to lift your right knee up. Right knee. Yep, up to your chest. Up. Good. And down. Good. And then compare that to the other side. Good. And down. Nice. Okay, again, we're just assessing for quality of movement. If they're moving straight up and down, or is there any diagonal component to it. And then we'll go through the quadrant, same position. Thank you. So from here, we're going to assist the patient to rotate, flip, extend with side flexion. Again, you're looking for any pain, and then repeat on the other side. Thank you. Okay, you can have a seat. Okay. In sitting, I would normally assess any neurological dysfunction, so dermatomes and myotomes working from L1 down to S2, doing hot and cold, deep touch, light touch, and blunt and sharp, and then assessing the myotomes as well. While in sitting, I also will do a slump test. So if you would sit back with the back of your knees touching the bed, good. I'll have your hands behind your back and relax your body forward, good. And then we'll start with this side, lift that leg straight, good. If they're able to do that, add dorsiflexion, so pull your toes up to your knee, good. And then assess if there's any pain, where the pain is. If there is pain, I like to ask them to lift the head to eliminate any or differentiate between muscular and neurogenic pain. Thank you very much. You can relax. All right. Once again, if you could have it, I want you to come stand over here, and you're going to sit down onto the bed and then roll back and just hug your knees. We'll do the modified Thomas test for back pain. That's it, sitting down, good. Roll back and hug your knees, good. Okay, so in this position, I like to position the sacrum in a neutral position. There you go, okay. Hold this knee with both hands. Don't move it from that position. So keep it there. This knee can just relax, let it fall to the floor. Okay, and here, laterally, I will look for iliopsoas length, as well as rectus femoris length. Rectus femoris seems to be a little bit tight. She's not able to get the knee down to 90 degrees. So that would be one indication there. And then from an anterior view, there's no internal or external rotation, and there's no lateral shift in the knee. You can relax it down to a sitting position. So the ITB doesn't seem to be too much of a problem. Let's have you laying on your back, please. Put your head over here. Okay, so I'll start off assessing SIJ dysfunction first. So doing a distraction test, assessing for any pain, asking where the pain is, not leading the patient into telling me the pain is at the back. On top of that, I'll add a squeeze test, just to once again find out where any pain might be, and what the cause of that might be. Next we'll do a straight leg raise, so if you keep your legs straight and just lift it up. Good, and down. side, good, and down. I like to do the straight leg passively and actively, so I will do it. You can just relax. No pain there, good. Add dorsiflexion with some medial rotation. If there's still no pain, that's good. And then obviously compare that to the opposite side. Then in prone, if you wouldn't mind laying onto your stomach, please. In prone, I'll start off just by palpating the spinous processes of the lumbar vertebra. So from L5 to S1, L1, as well as then palpation of the musculature of the paraspinals, comparing left and right, and then going into gluteals, glute min, glute med, glute max. And that should give me a fairly good indication of where possible problems could be. Thank you very much. Thank you.